Thank you, Dr. Eller, for the introduction. Good evening, everyone. So today I'll be doing a talk on challenges posed by COVID-19 on antimicrobial stewardship and its role in antimicrobial resistance. So I have no disclosures. Today's objectives are to discuss the challenges that SARS-CoV-2 pandemic has presented to antimicrobial stewardship programs. I would also like to discuss the impact of antimicrobial resistance in the care of COVID-19 patients. I would also discuss the impact of COVID-19 on antimicrobial resistance in future and also the challenges to antimicrobial resistance research due to COVID-19 pandemic and what mitigation strategies can be taken. So before I begin, I'll just go a little back into the history. I'd like to highlight a few important years in the landmark years in the history of antibiotics. So as we know, in 1910, the first antimicrobial drug, salvarsan, was synthesized that was used to treat syphilis. And then in 1928, Sir Alexander Fleming discovered the penicillin and began investigating its potential antibiotic role. Then we see that in 1941, Ernst Chain and Howard Florey began first clinical trials of penicillin. 1948, just in 7 years, we saw that penicillin-resistant staphylococcus became a global pandemic. In 1960, the first strains of MRSA emerged. And then we saw a lot of antimicrobial resistant organisms came up. And then in 2015, the World Health Organization launched the first Antibiotic Awareness Week. So as we all know that COVID-19 was declared a pandemic by the World Health Organization on 11th of March 2020. Since the first case that was identified in Wuhan, about 167 million people have acquired the disease and about close to 3.5 million people lost their lives. Antimicrobial resistance gained international attention in 2015 and was named a priority for global public health for 2020. Antimicrobial resistant infections are thought to have caused about a third of as many deaths as COVID-19 caused in 2020. So why do we need antibiotic stewardship? Obviously, antibiotics are a shared resource. Antibiotics are one of the most misused drugs in the hospitals. It's estimated that about 50% of its use is unnecessary or inappropriate. I'd like to highlight this poster by CDC, where they say that more than half of the antibiotic prescribing for selected events in hospitals was not consistent with recommended prescribing practices. In about 79% of patients with community-acquired pneumonia and 77% of patients with UTIs, the use of antibiotics was actually not supported. And again, like 47% of the patients who received fluoroquinolones and 27% of patients who received vancomycin, again, their use was not supported or maybe not necessary. As we all know that overuse contributes to antibiotic resistance and also causes the C. diff problem, which carries its own mortality and financial impacts. Antibiotics are leading cause of ER visits. They are not a benign agent, and antibiotics are responsible for most of the medication-related adverse events. Now, I'll highlight a few numbers here. It's very scary to see that 14,000 of the patients actually die of C. diff infection just in US. And the use of antibiotics is a major contributing factor in about 85% of cases. 23,000 patients die each year in United States as a result of antibiotic-resistant infections. And this number is kind of similar to the number that we see in Europe, where about 25,000 patients die each year from antibiotic-resistant infections. Another important number is 11,000 people lose their lives from MRSA infections in just United States. And then if you look at data from 2013, 480,000 people were infected from drug-resistant TB strains. It's estimated that by 2050, one person could die every 3 seconds if antimicrobial resistance is not tackled now. So how does antimicrobial resistance impact our COVID-19 patient care? So patients with COVID-19 actually receive antimicrobial for two main reasons. One is that COVID-19 symptoms resemble bacterial pneumonia. Patients come with complaints of fever, cough, shortness of breath, and it's very much, and even the lab abnormalities are some of them kind of indicating to bacterial pneumonia, like we see elevated CRP, we see elevated procalcitonin, and some of the providers are inclined to the use of antimicrobials in those patients. Second, the patients with COVID-19 acquire secondary co-infections, which require antimicrobial treatment. We rely heavily on our local stewardship data. If there is high number of drug-resistant and microbial infection, then we tend to use empiric antimicrobials that would cover for those drug-resistant infections. Say, for example, if an area has high carbapenem resistance, there is a tendency to empirically use colistin, which comes with its own adverse effects and cost, and also promotes antimicrobial resistance. So I like to talk about these two papers. One of the meta-analysis was done by Langford et al. In this paper, they discussed the prevalence of bacterial co-infection and secondary infection in patients hospitalized with COVID-19. And actually, they found out that this rate was pretty low. The bacterial co-infection rate was as low as 3.5%, while the rate of secondary infection was about 14.3%. In another study by Rosen et al., they did an analysis, and they reported that about 8% of patients that were included in the publication actually had bacterial or fungal co-infection. But about 72% of the patients were treated with antibiotics. So we can see, like, out of those 72%, probably just 8% actually needed the antimicrobials. Some studies from the Chinese, like in some Chinese randomized trials that were evaluating the use of remdesivir and Caletra or lopinavir ritonavir combination, about 90% of the patients were treated with antibacterials. So how does COVID-19 impacts antimicrobial resistance in future? So I like to talk about the evolution of AMR. We know that AMR, or antimicrobial resistant organisms, after emergence, they're transmitted to other patients, and once it transmits to a significant number of patients and those with multiple comorbidities, they cause the infection in these patients. And COVID-19 has a tendency to affect all these three components through direct or indirect consequences to pandemic responses. Now, government interventions like travel restrictions or non-essential service closures, physical distancing, mask wearing, all these have impact on the supply chain of the antibiotics. It all, particularly the travel restrictions, causes supply chain disruptions and healthcare access to these antibiotics. And again, all these have an impact on the antimicrobial resistance. So if we look at this antimicrobial use in the patients with COVID-19, 70% of patients with COVID-19 receive antimicrobials, either inpatient or outpatient. COVID-19 sometimes presents with non-specific symptoms and that are mistaken for other diseases, which results in inappropriate prescribing and misdiagnosis. COVID-19 survivors develop structural lung damage that require frequent antibiotics with resultant colonization or infection with resistant organisms. Antimicrobials used for their presumed direct effect on SARS-CoV-2 has led to resistance emergence in co-infecting or co-colonizing pathogens, which is called a bystander selection. An example would be like the use of chloroquine or hydroxychloroquine in some of the countries where there is still chloroquine-sensitive Plasmodium falciparum infections around. And a lot of excessive use of chloroquine can actually induce resistance in those pathogens. Again, and then we see that there were certain rapid publication of some of the papers without extensive peer review, and those were endorsed by WHO and CDC without evaluations. Use of hydroxychloroquine, chloroquine, and azithromycin for the treatment of COVID-19 use has now been stopped in the US, but because of misinformation, lack of other treatment options, severity of the illness and desire to try all the options has led to their continued use in some of the other countries, particularly in those countries where medications like remdesivir or tocilizumab are not available. They are still relying on these medications and even ivermectin to see like if they have any positive effect on these COVID-19 patients. So in this first graph, I'd like to show the use of azithromycin. This is taken from the National Healthcare Safety Network. As we can see that compared to 2019, in 2020, the use of azithromycin, particularly in the months of March and April, went up significantly, was more than 35% as compared to 2019. Now, once we got some studies done that showed that actually the use of azithromycin is not doesn't do any good for the patients, the number declined steeply, but still in the few beginning months of the year of 2020, we saw significantly increased use of azithromycin. And this second graph is actually to show the spectrum of the medications that are used for COVID-19. We can see some antiretrovirals that were used, some anti-inflammatory medication, antibacterial, antiviral medications, even like ivermectin are even still used in some of the countries. So if we use these many different kind of medications, and if there is improper use of all these medications, that can again lead to antimicrobial resistance and future risk of development of these resistant organisms. This here I'm highlighting the recommendations for the antibiotic use, and I've quoted here the guidelines from Surviving Sepsis Campaign, World Health Organization, and the NIH. So there is no consensus in these guidelines. If we look at the Surviving Sepsis Campaign guidelines, in mechanically ventilated patients with COVID-19 and respiratory failure, they actually suggest the use of empiric antimicrobials and antibacterial agents, even though the recommendation is weak. Whereas World Health Organization does not recommend the use of antibiotics or antibiotic prophylaxis for patients with mild or moderate COVID-19. The use of empiric antibiotics in severe COVID-19, WHO has left it for clinical judgment, considering the patient host factors and local epidemiologic data. And they also say that those patients, like older people residing in long-term care facilities and children younger than 5 years with moderate COVID-19, actually they say that we can still use empiric antibiotic therapy in these patient population. Whereas NIH, on the other hand, says that even with severe or critical illness, there is insufficient data to recommend empiric broad-spectrum antimicrobial therapy in the absence of another indication. And even if we do start antimicrobials, we should reassess them daily and try to minimize the adverse consequences of unnecessary antimicrobial therapy. Now, how has COVID-19 affected the antimicrobial availability? So the biggest impact has been on the antimicrobial supply chains. There has been uneven supply in some of the countries, which again raises the concern for resistant organism emergence and from the suboptimal antibiotic use. I'll use two examples, like UK relies heavily on the import of antibiotics, and because of certain restrictions in travel and the supply of the antibiotics, there were shortages of antibiotics in UK. While on the other hand, countries like India, which actually exports these antibiotics, had to keep the antibiotics for their own pandemic control measures. So definitely, like, COVID-19 has a big impact on the antimicrobial supply chains. And again, we can see some of its impact in future on the antimicrobial resistant emergence. Some of the countries actually gave authorities to some of the companies which did not produce well quality antibiotics, and they actually produced some substandard and counterfeit drugs. And again, these suboptimal concentrations can favor the resistance. Some of the antibiotics were not available, which targets specific microbes, and some physicians were forced to use broad spectrum antibiotics that again can cause antimicrobial resistance in future. Uh, People who need continuous antimicrobials for TB treatment, if there is short-term treatment interruptions, that can again lead to treatment failure and development of resistance. Now, if we talk about COVID-19 on the financial aspect, it has definitely caused a reduction in the overall wealth of the nations. In high-income countries, we know that people need prescriptions to get the antibiotics, and this reduction in the income is associated with poorer health because people try to avoid going to the hospitals, and in the absence of getting the antibiotics on time, they are at risk of getting respiratory infections. And in contrary to that, in the lower or the middle income countries where the antimicrobial purchasing is less regulated, again because of financial hardships, they try to avoid going to the hospital, and they get the antimicrobials over the counter, which results in shorter course or subtherapeutic antimicrobials, which again can lead to increased mortality. Now, on the other side, if we look at the infection prevention measures taken during the COVID-19 pandemic, there are certain papers that argues actually that with increased infection prevention control measures due to COVID-19, antimicrobial resistance can actually decrease in future. They say that for multi-drug resistant TB, majority cases result from transmission events rather than acquisition of spontaneous resistance from emerging during the treatment. One other aspect of this story is that with limitations, with increasing physical distancing, there is a risk of transmission of infection within the same household. If the people are restricted in the same household with say open TB cases or other infections. Next, I'd like to talk about the infection burden in the healthcare setting. So patients with severe COVID-19, they are hospitalized for prolonged period, and they are at risk of acquiring nosocomial infections. These patients actually receive multiple courses of broad spectrum antibiotics, other like organ support, mechanical ventilation, and again, all of these can increase the risk of hospital acquired infection with resistant microbes. One of the other factors that increases the risk of nosocomial infection is again that we saw that the shortage of PPEs in the early pandemic time, and also shortages of the staff, because a lot of the staff, people from the staff were actually infected with COVID-19 and were unavailable. So again, all these factors increases the risk of nosocomial infections. Now, I'm bringing up these two articles that were published in the Journal of Antimicrobial Chemotherapy. They've actually started a series about the pro side and the con side of the COVID-19 pandemic on antimicrobial resistance rates. So in this first paper, Cornelius Clancy and Diana Pearl argue that COVID-19 pandemic will result in increased antimicrobial resistance. They are in favor of the theory that broad spectrum antibiotic use is common among hospitalized COVID-19 patients, and excess of reported secondary infections suggesting unnecessary prescribing, and disruptive direct and indirect effects of COVID-19 on economic systems, governance, and public health expenditure will actually fuel the AMR spread. Whereas on the other side, Peter Collignon and John Braggs say that antimicrobial resistance is affected by many factors, and too much of our focus is being on antimicrobial usage. And they argue that the major factor that drives the resistance rates globally is the spread of the infection and not the antimicrobial use. COVID-19 pandemic should lead to improved infection prevention and control practices, both in the healthcare facilities and in the community. COVID-19 will also have ongoing and profound effects on local, national, international travel, and all of these factors should lead to decrease in the spread of resistant bacteria. Now, how has COVID-19 affected the healthcare system? It has caused clinical care disruptions. About three-quarters of the programs and service deliveries for HIV, TB, and malaria have been disrupted as a result of the COVID-19 pandemic. This again causes delay in diagnosis and treatment, and those individuals which actually have the resistant organism infection can actually spread it to the other people and spread the infections. And for diseases that require long treatment like TB and HIV, interruptions to treatment and suboptimal adherence can contribute to relapse and again resistance. There have been changes to the health-seeking behavior, as I was talking before, that in high-income countries, prescriptions are needed for antibiotics. People are trying to avoid going to the hospitals, and a short-term reduction in the overall antibiotic use can actually reduce the emergence in short term. But if we look at the bigger picture and if we look in long term, then these people who delay the treatment could actually have worse outcomes, and it can lead to high rates of hospitalizations and need for more or different antibiotics. To counter this reduction in the health-seeking behavior, a novel strategy was adopted to do telemedicine. But again, this has some of the studies are coming up that shows that even with telemedicine, there has been a tendency to practice just-in-case antibiotic prescribing, where patients who because the physicians cannot actually see the patient in person or examine them, and patients come up with trivial symptoms or some complaints that doesn't warrant antibiotics, are actually prescribed antibiotics for a short course. Vaccination. So again, COVID-19 has impacted vaccination of vaccination coverage throughout the world. One of the indirect impact will be the surge in vaccine preventable diseases and their associated complications, which again will lead to increased antibiotic use. So what is the future of the AMR research, and how has COVID-19 impacted that? So antimicrobial research is likely to have slowed substantially in the first half of 2020. The reason is that most of the staff, including the ID pharmacists, technicians, equipments like PCR machines for diagnostic laboratories, reagents, they were all deployed for COVID-19 research. So what can be done about this? That the researchers should be supported to continue the antimicrobial research work. The new networks of collaborators formed to tackle the COVID-19 issues should work in future research plans to tackle the problems of antimicrobial resistance. We need multidisciplinary team strategy to tackle the problem of antimicrobial resistance. So research and health system priorities. So what else can be done about this? Diagnostic wise, investment needs to be done in diagnostic logistics, used for rapid detection of both the causative agent of infection and any associated drug resistance. Data collection for infectious disease needs to be strengthened. This is particularly important for antimicrobial resistance, which often relies on passive surveillance. Cost for screening for COVID-19 in most settings is being borne by the government, but screening for the drug-resistant pathogens like CRE is actually paid by the hospital or by the patient themselves. Understanding the funding model and how it could change the economic impact of antimicrobial resistance can lead to better screening and hence monitoring of the antimicrobial resistant organisms and prevalence. Antimicrobial use. Much of the high antimicrobial use in patients with COVID-19 is unavoidable. More research is needed into better understanding of the risk factors and prevalence of co-infection in patients with COVID-19. to support the reduction of any avoidable antimicrobial prescribing. Health system is strengthening. COVID-19 has definitely highlighted many weaknesses in our health system. WHO has called for a broader pandemic response. This has to it needs to be ensured that continuity of the health services through regular supply of antimicrobials is maintained. People who need antiretroviral medications, TB medications, it needs to be ensured that these patients receive their medications on time and there is no interruption in the treatment of these infections. Inequalities, as we saw across the world, inequalities are rising between and within the countries. COVID-19 has rendered health impacts of these inequalities, and it was quite visible in the tragic terms. We need to determine if any existing inequalities lead to synergistic or multiplicative impacts on both the AMR and COVID-19, and work needs to be done to develop and evaluate the mitigation strategies at all levels. Policy-wise, the pandemic has exposed weaknesses in national and international organizations like CDC, WHO. These public health bodies are key to coordinating the AMR responses, and work needs to be done to support these organizations. So I'd like to talk about the takeaway points from this talk. Modifying the processes of emergence, transmission, infection burden. The COVID-19 has changed the landscape of antimicrobial resistance. Whether antimicrobial resistance will be reduced in the face of efforts made to curb COVID-19, or the use of antimicrobials to treat COVID-19 will increase antimicrobial resistant organism prevalence. This is something that we'll know in future, but we should always start working and think about it ahead of time. Continued research that measures the responses, measures and response to the crisis of COVID-19 with future systems that support continued antimicrobial stewardship. Though the public health community has been focused on global COVID-19 pandemic, the antimicrobial resistance has not gone. Antimicrobial stewardship activities should be integrated into the pandemic response. While the impact of COVID-19 policies on drug-resistant pathogens is still unknown, it is clear that there will be a shifted set of AMR global challenges going forward. We now need to work as a multidisciplinary community to gather data on these changes and solve the arising challenges collectively. So I'll end my talk with this very famous quote by Sir Alexander Fleming. The thoughtless person playing with penicillin treatment is morally responsible for the death of the man who succumbs to infection with penicillin-resistant organism. These were my references for my today's talk, and thank you for your attention. And if there are any questions, concerns, thoughts, really appreciate it.